Everybody. We're continuing on our meeting today, and we're going to continue on with Megan from D4 Practice Solutions. So I'll hand it over to you with your presentation.
Okay, well, good afternoon, everybody. Thank you so much for having us. We are going to talk, or I'm going to talk today about this whole workforce situation that we find ourselves in throughout dentistry. I know it's not just us, but we're going to concentrate on dentistry today. And what can we do? I think we're all understand now that we're at where we're at with our workforce. We hope we can get more. We hope we can fill all of our gaps, but for now, it's probably not going to happen today or tomorrow. So what can we do to keep our programs going with staffing shortages? And then we're going to talk a little bit about building a positive culture. So I do have a couple of slides about understanding what's going on with retaining staff. I'm not going to get into recruiting so much. I think we're all really good, with understanding what we need to do to be competitive in the recruiting world. But there are some things that we can learn from some recent reports that may help us make some decisions in how we can change things a little bit more to retain more staff. And then if you've heard me speak before, and if you hear me speak again, you're always going to hear me talk about the critical value of the revenue cycle and why we as clinicians need to take a little bit more of an active role in that cycle. And then we'll talk about workplace culture and how that acts to retain our staff. So this is, some of you've probably seen this. This is at ADA Health Policy report that came out, I believe it was the end of October. And I don't think that all of the information was shocking. I think we know that we have a reduced capacity. What interests me is that this is public health and private practice dentists, but 1 in 3 don't have full schedules, and they're citing shortages as a contributing factor in that. Now, I did notice at the in the November report, there's a little bit of improvement in staff shortages for the private practice dentist. There wasn't any information on the public health. We didn't have enough responses on that for them to post it. And then, we like to blame COVID for at least being the start of our staffing shortages, but we've noticed a downward trend in dental assisting programs since 2015. So I think COVID was the last straw for a lot of people. I think we see that with dentists who were in that 5-year plan. I think a lot of them just said, I'm not dealing with that. And so we had more retirements than what we thought that we would have. And here's what really concerns me, is that we're not expecting any type of significant rebound in the near future for formal dental assisting programs. I think what that means for us is that if you have a state that allows it, we need to look at in-house training site or program. So that was a huge discussion at the NOAA annual conference. There was a lot of great information about in-house dental assisting training programs. If you're interested in any of that information, just email me. I'd be happy to send you what we have on that. So here's another thing from that report. 34% of the dental assistant workforce who responded to that poll says they're going to retire in 5 years or less. What I don't have on that slide, it was over 30% of dental hygienists who answered to are planning on retiring in the next 5 years. Now, I don't know if people looked at their 401ks before they answered that. That might be a little bit different now, but it's really something that we need to really look at and use for our planning over the next 5 years for our dental programs, because that potentially can be a significant problem for us, challenge. And 40%, I think we know we're we're competing with everybody now, but it's not just other dental practices. We're competing with Amazon for staff. We're competing with Walmart. You know, we're competing with just about everybody right now for dental staff. But I did put this little graph up here because I thought it was interesting. The majority of dental assistants are satisfied with their current job. And, you know, we're kind of neck and neck with private practice. So we're doing a good job in our health centers, I believe, of keeping our staff satisfied. So the ones that are leaving, why? This again was from that report. Insufficient pay was the most common cited reason. I did do a little bit of research on Arizona. You guys are 16th out of the states for dentist salary, and average dental assistant in Arizona is at $22 an hour, and hygienist $41.95. So, you know, you guys seem to be pretty good with your salary, with your salaries there in the state. The culture of the organization, you know, we've been talking about this for a long time. It's very interesting to me when we talk to private practice dentists. This is new to them, this organizational culture, and having to really focus on that aspect of being a business owner. But in health centers, we're pretty good at this. We've talked about it. We have some plans in place. Overworked, to me, in health center dentistry, this is one of the toughest things. Our patient population, as you guys know, they're more complicated to treat. We're exhausted at the end of the day. And then inadequate benefits, which I don't think in any way is us. I think that came from the private practice field. And that's a big discussion in private practice right now, is giving better benefits to their staff, which then has revenue implications for them. So let's get to retention. Be a great place to work. I think we're trying to do that. We really are trying to do that. So what do employees want? They want good wages and they want benefits. That's a check mark for us. I know that sometimes we can't be as competitive in the wage department, but I think that when we balance it out with the benefits that we're able to provide, we kind of even that up. Opportunities for advancement. Again, this is somewhere where we really have an advantage. I'm a dental hygienist by training. I've been in the dental field over right at 25 years now. And I've spent the majority of my career in safety net dental clinics. I started in an FQHC as a clinical dental hygienist. I ended my full-time FQHC career this past June when I came full-time at D4 as a dental operations manager. Now, in that time, I did go back to school and get my master's in health administration. So I did my part, but that would never have happened to me if I had remained in private practice. So that is one area where we can really benefit with the way that our centers work. Flexible work schedules. As a manager, an operations manager, I hate flexible work schedules. You want to know why? Because it's harder for me to make sure everything's scheduled. I think if we're going to give in one area, if we are not providing flexible work schedules for our staff, I would encourage you to consider that and see if it would work for your center to do that. And then the work-life balance. This is relatively new for me. When I started out working, we never talked about work-life balance, but it's really important. And we like to, those of us that are older, we might just jokingly most of the time about millennials, but we raised them, at least I did. My kids are in that age group. And I think that we did a really good job with that, showing them that there's more to life than just working. Now, though, we're having maybe a little bit of problems from too many people wanting too much of the life balance. Safe work environment, we do that. We're awesome at that in health centers. Non-toxic work environment, I think that we're on top of that too. To work with or for good leaders. I don't know who does work that's more rewarding than we do. I think in the health center world, and one of the things that I have found with dental staff especially, is that we tend to concentrate on the need we're not meeting. And if we do that, it becomes very overwhelming, and it's hard to feel any sense of satisfaction for what you are doing. So one of the key things I put in place in my center is to make sure that the staff understood what it is that they're accomplishing every day and the difference that they're making in the people that we are seeing. So I did that through a dental dashboards. We're not talking about that today, but if you don't have a dental dashboard, I would encourage you to consider that, because it really does measure what your dental team is doing every day. And then to feel valued and appreciated. We all want to feel valued and appreciated. So what can we do? And this is one advantage of what we do at D4, is that we go into a lot of health centers throughout the nation. None of this stuff is coming from us. We have stolen all of this information from health centers around the country, and I just get to sit here and present it to you. But salaries and benefits, competitive as we can make them. Here's something too, at least in my center, we were doing this with providers, but we were not doing it with auxiliary staff. And that's to make sure to give the total compensation sheet to people during the interview process, so that they can see that totally what they're going to make. Because like I said, that's one of our main advantages in what we do, is that we have generally really good benefits that we can provide to our employees at health centers. So making sure that you have one that's job appropriate. Don't show them the dentist one, but make one for dental assistants, make one for dental hygienists. You can be general with the salary level that you go to, and then make sure that, and I have an example of one, so we'll hit that, but make sure that you're showing that to people in the interview process, because you might not be able to meet your private practice colleagues can do. We just don't know. Consider incentive programs. This is a tough one for us. We always say incentive programs are great if you're breaking even. If you're in the red, then it's really hard to do that, but now's a little bit different. So maybe that is something that you want to take a look at. We recommend, if you are going to do it, that you do it all staff. I think all of us here who are in the clinics and our health centers understand that there are no secrets. So if you have incentive program for certain providers or just for the dentist, but not everybody else, I can guarantee you the rest of the staff knows that. So consider if it's possible, and if you're in a position to be able to offer an incentive program, to do that. Consider the quality of the work experience. I have a slide on that, and what exactly does that mean, and what are some things that you can do to improve the quality of the work experience with your staff. And here's one thing, again, from a manager standpoint, this is really tough, but it is vitally important that we know what our total capacity is, that we're working to that capacity, but we're not working over capacity, because it's too much on the dental staff, especially if you're working short-staffed every day. So capacity means you can see as many patients as you have the resources to see. How many operatories, staff, how many staff do you have? And then you have to go by that. And you know what? Our capacity changes sometimes every day. You just sometimes you go through these phases, you don't know who's going to be there. So I think in FQHC dentistry, in my experience, we've always been really good with call-offs traditionally. We don't really reschedule a lot before. And we made it work. It was a tough day, but everybody came together and it was manageable, but it's not sustainable. And that's where we're at right now. So when we have staff shortages, we already have a team that's burnt out. We're already dealing with all of these other things, and then we're being asked to see more patients than what we can. So really right now, rescheduling if you don't have the resources to see those patients that you have in your schedule is what is recommended. Short term, it's going to get better. I think those of us who have been in dentistry for a long time, I don't think we've seen it at this level, but we've gone through this before and we know that it's going to turn around at some point. And then again, staff burnout, not only staff, we're all burnt out, aren't we? So really some self-care is really important right now for all of us. So here's that total compensation package. And this is just an example of something that you can present to people when you're interviewing. It's also a good idea to provide this information to your staff at the end of the year so that they can see what it is that they got paid other than what their salary is. So you can see that the total annual salary and the total compensation package are very different. However, that the total compensation package is actually what you have. The thing I caution if you do this, it's very important that you make sure, because remember, we're spreading it out. So we're not into other auxiliary staff. We're not just talking to dentists. We need to make sure that we're really clear that that bottom total compensation package does not mean that's what's going to be in their available paycheck. It's going to be on their paycheck every pay period, but it's not going to be what the monetary check is for. So we need to make sure that we're very clear about that. So there is no miscommunication as far as what somebody's getting paid when we don't want surprises on their first paycheck. That's a mad person in the dental director's office. So I want to talk just a little bit about specifically dental assistants. I think nationally right now, the dental hygiene shortage is just a little bit more concerning for most than the dental assistants. In my area, that's not the case. Not that we don't have hygiene shortages, we do, but we have a hygiene school in our area. And so it's not as much of a concern as the dental assistants. So one thing that we found is that dental assistants, especially those who are trained on the job, they struggle. They struggle a lot of times, especially in FQHCs, with what are we? What is it that we even do and how is it different? It's really hard once somebody is starting and we have them in the chair assisting dentist to take the time away to really do any type of a orientation program. So a formal orientation program that includes education not only on dental assisting, but also on what it is we do as in an FQHC. Career ladders, we have talked a lot about that. If you're interested in a career ladder, we at D4 have tons of resources that we can send to you on what other health centers are doing with creating ladders for dental assistants. So you would have, for instance, it would be a trainee would be level 1, and then a dental assistant that can do whatever it is you decide they're going to be able to do would be level 2. And then you would go up with that until your top level would be expanded functions, whatever, excuse me, whatever that is in your state. So again, like I said, we have a lot of these resources. We got a lot more from NOAA, the NOAA conference. So a lot of health centers are trying these career ladders. Here's the thing with career ladders, though, they have to mean something to mean something. So if you're not increasing their pay rate with their steps in the ladder, then probably you're not going to have a lot of assistants that are going to want to take on added responsibility. And that's what the ladders seem to all be, where each step, the assistant has more responsibility. Steps, they may be responsible for sterilization. They may be responsible for, all the OSHA regulations or whatever it is that you want to give them. But there does need to be a higher sense of responsibility for each ladder. And then also tuition reimbursement or sponsor. Maybe your health center can sponsor a really good dental assistant that has proven that they have a good work ethic and a good attendance record, and they're wanting to get some more advanced education, whether it's going on with assisting, or whether they want to switch to dental hygiene. It's a great idea to see what your health center can do to help them accomplish that, and then hope that they come back. So ideally, we want to see one assistant per operatory. This is part of that burnout with dental assistants. They feel like they get the brunt of the work, and you know what? They're right. They do get the brunt of the work in most dental centers. They're the workhorse of the center. They're the ones that, you know, when I have an issue in my operatory, I go to the dental assistant because I know that they're going to be able to help fix my chair or fix whatever it is that's occurring, or ask me if I've changed the O-ring anytime soon. You know, those, or recently, those kind of things. So they're really good at that. We rely on them a lot in dentistry. I like to call them the traffic cops of dentistry, and that's truly what they are. They're also experts. I learned this as a operations manager. If I had a question about the dentist schedule, especially if it was a late patient situation, or if we had a walk-in patient, I knew that if I went to the dentist, they were going to say yes, and they weren't even going to look at their schedules to see if it was possible for them to do it. The assistants said yes when they could. What I found is when they said we can't do it right now, they always gave me an option. Can they come back at this time? And you know what? It worked out better than they just have such a great hold and overview of what the dentist schedule is for that day. And that's not always true from the dentist. They're being pulled in so many different directions. Sometimes I think they don't even know where they're at. Some days that's how busy we keep them. And then here's another thing. We do exit interviews. I think it's a good idea to look at doing stay interviews. So your longtime staff, bring them into your office and ask them why it is that they stay. I did this, and I wasn't surprised, but the main answer was that they just enjoyed helping our patients. They felt like they were making a difference with our patient population, and they certainly were. So here's that quality of work experience. And I think that there's some realistic things that we can do that are not going to cost a lot of money, that can maybe help in the retention piece. So how does it feel to come to work each day? Hopefully, nobody here knows what it's like to have a headache or a stomach ache when they get in the car to go to work in the morning. If you do, you know how miserable it is to go into a job that you hate. There is no reason to hate what we do in health center dentistry. If they do hate it, then we need to figure out what it is. Are we understaffed? Are we asking too much of them? Are we putting too many patients into the schedule? How attractive is the work environment? So, maybe all it takes is to make people happy is some paint on the walls, or art, or let them have plants into the operatory. Some of us don't have. I didn't work with a window. I hated it, but I could bring some plants in. Thank goodness for what are those little succulents? I am not a plant person, but I can make a succulent stay alive for a while anyway. And then, is the dental equipment in proper working order? And this is a huge complaint. When we go into health centers to do assessments of dental programs, we do a confidential staff survey. Our dental staff are extremely open and honest with what they feel our issues are in health centers. And I think that that's awesome. It really helps us to see where it is that we need to improve. One of the other things when we do the on-site interviews with dental staff is the dental equipment in proper working order. If something's broken for too long, if they are short of instruments, if they don't have the materials that they need, or the PPE, it just makes for a really stressful and chaotic day. So making sure that you have your good equipment in proper working order. That doesn't mean it has to be brand new. I mean, I'm a big believer in some of the older equipment that I worked with. I liked so much better than when they replaced it with something new, but that could just be because I'm old too, and I was comfortable with that equipment. employee feedback on work satisfaction. Here's the thing with staff surveys. Many of us do yearly climate reports, is what we called it at my health center. If we're going to do those, it's important that we follow up on them. We made the mistake of doing it once and then we didn't have any follow-up, and it wasn't because our administrators didn't care. There was a lot of other things that just came up after we did that, and it was put on the back burner, and you know how that goes. Sometimes it gets forgotten about, and it was really not a good thing. It caused a lot of dissatisfaction with our staff. So when we did it the next time, we made sure that we had a formal process in place before we gave the climate interview on what each step was going to be. We were going to do the interviews through SurveyMonkey so that they were confidential. And then we were going to go back to our staff with some of the issues that they had to get more specific information on what, like communication. Everyone says communication. We know that that's a problem in health centers. But when you try to delve down into what exactly do they mean by communication, it can become a little bit more convoluted, but we need to know that in order to be able to fix those issues. We talked about the flexible work arrangements. I think most of us are taking a look at our schedules and seeing how we can be. Here's something too. Patient abuse of staff. We know that it happens. We know that our population, some of them have a lot of medical issues. They have behavioral health issues. We have to be, I think, a little bit more tolerant in some areas. But when you have somebody yelling at your staff, and I can tell you that it happens. I've had to intervene many times, especially if you're telling a patient something they don't want to hear. They don't want to be referred out for an extraction. They don't understand why the dentist can't do it right there. Their friend got an extraction. So those are the kind of conversations that your front office staff is having daily. And sometimes it can get out of hand. So if a patient is abusive to your staff, then we need to have a zero tolerance policy. It's within your organization, figure out what your hard line is and then stick to it. Make sure there's a formal policy and that everybody is aware of it, including your patients. We're trying to fill staff openings as quickly as we possibly can. So I think that we're doing everything that we can with that. And here's another thing that can be tricky in health centers. We all go about budgeting our visits a little bit different. One thing, especially right now, is to make your visit budget realistic. Make it something that your dental team can actually accomplish. Nobody wants to go in and fail every day at a job. That's the quickest way to burn out. So I know some places like to kind of adjust to make the budget balance. And if that's your goal, and if that's how you work it, that's okay. But just consider maybe in this next budgeting period, pulling back a little bit on that if your team isn't making their visit budget now. And then some things that we can do that they cost us, but we don't have to increase pay. And, recognition and praise, it's small, but it matters. Just stupid little things. I bought socks for every holiday for my staff, and then we had crazy holiday sock day. It was fun. It didn't cost a lot of money. It was, I don't know, $50. You can get a whole pack of stupid socks on Amazon. And it just was something fun that we could do. Communicate. Morning huddles are a great way. If you're not doing a morning huddle, I would recommend you consider it. I have some templates that I can send to you that will help you facilitate those meetings and make them quick. But what I have found with huddles is that you can start the day on a fun note. So you have to discuss some patient-oriented things, but you can do something fun at the end of those meetings. We had a stupid fact at the end of the day, and we took turns coming up with, researching stupid facts, and it became a fun thing, and we all really looked forward to it. We also did a weather update. So if you live in snowy areas, people know that there's going to be snow, and so you hopefully don't get, as many calls that people are going to be late. reinforce the value of what they do. We talked about measuring quality in your dental programs with a dashboard. The catering lunch, we may or may not be able to do that, depending on what our finances are in our centers, but we can do theme days. The same thing with listen, if you guys are giving massages, I am working for you. So you let me know if you're going to do the in-office massage thing. Birthday cards are another thing. Here's the thing with birthday cards, though. If you have a large organization and you're sending birthday cards, it gets very expensive because of the postage. So something to consider before you decide to do that. But you can get cupcakes or, have fun contest. So I want to switch gears now and talk a little bit about, okay, we're doing everything we can for recruitment. We're doing everything we can to retain our staff. What do we do in the meantime to make sure that we can keep offering dental services to our communities? I'm a data geek. I love data. And so I love this quote because it's so true. And I think one of the communication issues we have between our clinical staff and our administrative staff is that we speak dental and they speak numbers, but they don't necessarily speak dental. And so there can be some confusion there. But if you just stick with the numbers, which we're good with too, we can show exactly what we're doing, where our shortcomings are, where we can improve easily, and what we need to think about in the future in improving. So I wanted to start with data here. This is a comparison. This is national UDS data with 2019 and 2020. And no surprise, we all know that our visits were way lower in 2020 due to the shutdown, and that our cost of care rose. But you can see between 2019 and our last UDS of 2021, we're getting back up there. So there's hope. We've brought our cost of care down. We've increased the number of encounters. I don't think that COVID is really a significant factor like it was before in our patient flow. I think now it's mostly staffing that's creating an issue. I did do a little quick, well, where is it? Okay, well, I did a quick Arizona and between Arizona and the UDS. So I can tell you, even though I don't know where the slide is, that Arizona was a little bit down for the dentist encounters. I think that you guys were around, and this is Arizona as a whole, no specific health center. I think you guys were around between 1,600 and 1,700 encounters per FTE dentist. You were right on with hygiene. I think you were 965. You were a little over 300 costs per visit, so a little bit higher than what the national average is. But I think that might have something to do with salaries being so high. Your expenses were higher than a lot of the other states that we see. So what does this information give us? Here's what we need to do in our programs. We cannot control how many staff we have. We can't control if somebody is sick or not, but we can control some of the things within our centers to make sure that we are being as efficient as we possibly can. That is so important right now. Payer mix has a huge impact. I did look up to in Arizona, overall, you guys are around, oh, it's going to be on the next slide, but you have a pretty high commercial insurance rate in your health centers. So that's an advantage to you to be able to maximize that revenue through your commercial payers. I think that you guys are just adult emergency benefits right through Medicaid. Yeah. Provider productivity, again, we may or may not be able to have anything to say about that. It just depends on who's there. Fees and discounts is something that we can look at, and we're going to talk about that when we get to the revenue piece, and then making sure that our collections are where they need to be. And this is that revenue cycle that we maybe didn't get involved in as much in dental and our management clinical leadership team, but we really need to take a look at these on a monthly basis and make sure that we are maximizing every single thing that we can. There's nothing more demoralizing than working hard every day, but it doesn't matter because we don't get paid for it, as far as the sustainability of our programs go. So this is Arizona here, one of my Arizona. So it's coming up next. Arizona slides here. This is aggregated through Arizona, 33% under 21, and then 67% of your population is, and your health centers is over 21. And then you can see the payer mix for you guys. And again, this is just information for you to keep on your own. You know, you calculate these for yourself, or have your IT department get these numbers to you on a monthly basis, or even every 6 months, so that you can just kind of keep track of who you're seeing. Because when I look at that, I think, okay, well, can you increase the number of children that you see? Because that's going to increase the number of encounters that you have. Here we go. Here's how did I do? Oh, not too bad. So yeah, I was kind of right on with there. There's your numbers for Arizona aggregated compared to our national UDS data for 2021. One of the biggest places where we're losing efficiency that we have found at D4 when we assess dental programs is the dental schedule. It is the most important piece of your operations, is making sure that your schedule is maximizing access to care, because that's what we're there for, that we are maximizing outcomes. That's that treatment plan completion, which can be really difficult for us if we're having too many new patients come into our centers. And then this is also what allows us to maximize revenue, which again is something that we need to think about right now, getting paid for every single encounter that we do. But we talked about burnout. So managing to capacity is important. So we need to resist adding too many new patients. I know that that is hard, and that can be a really tough conversation, but a really critical conversation between the dental leadership and the administration, just to make sure that everybody is on the same page with how many new patients we can accept into our practices, because we have to be able to complete treatment plans. If we're just diagnosing dental disease but not eliminating dental disease in these patients, what really are we doing to help them? We're just telling them that yeah, you got problems, but we're not able to actually help them resolve any of those. So resist the temptation to overschedule to compensate for broken appointments. Broken appointments can be managed without over scheduling. I know that it makes sense. Some of us in D4 were totally anti double booking. I personally am not. I double booked, but very strategically on our scheduling. Resist the temptation to shorten appointments unless you're already over scheduling or have too long of appointment times, especially if you find that you have a lot of 6-year-olds in a 1-hour appointment slot for hygiene. That is something that you can take a look at. And then make sure you're fully utilizing your resources, staff hours. What I'm seeing is more dental directors taking on a couple more hours of clinical care. Before I left the center, I did the same thing as a clinical hygienist. I haven't done clinical in a couple years except for filling in, but I did take on 8 hours of clinical care. And I know it's hard. So if you're going to do that, it's hard. You're going to be crazy for a little bit trying to get everything done. And I never got through an entire appointment without being interrupted for something. But I did what we had to do to help get our encounters up a little bit. So broken appointments are one of the biggest killers of productivity, revenue, wasted chair time, which we all hate. It diminishes our access. We can't complete treatments. It creates a chaotic environment. We're all frustrated, including the patient. So we all laxed a little bit through COVID with our broken appointment policy. I'm recommending that you take a look at that. It may be time to pull back on that relaxation and really go back again to a strong policy. This is going to depend on what your no-show rate is. If your no-show rate, if your broken appointment rate is 15% or less, this might not be something that you want to concentrate on. We consider broken appointment to be no-shows and less than 24-hour cancellations, because those are the appointments that you are least likely to be able to fill last minute. So if you're only doing no-shows and you're not measuring less than 24-hour, you can probably do that for yourself or have someone in your ID department run that for you unofficially, or, you know, maybe you're not going to report it, but it's good information for you to know how are we actually doing with open appointment times. If you have an issue, we had an issue. I instituted a strong policy. We did a 3 strikes and you're not out. You just have to call us every day and we're happy to get you in if we have an opening, which worked out a lot of times. And we went from over 30% hygiene no-show rate to 12%. So it took a year. So it wasn't instant, it took a year, but everything in dentistry takes a year, it seems like, because of, especially for hygiene. We also stopped scheduling 6-month recalls. We're not talking about that today, but that is another thing that I did when we came back from COVID and had no schedule at all, first time ever. So whatever you decide to do with your broken appointment policy, be consistent, make sure that where you're documenting that is easily found for your front office staff. If you have a separate call center that is not only dental, then it's going to take a little bit more hands-on with their management team to make sure that they're on the same page as a dental team and understand exactly what the policy is and how to go about scripting that to the patient. Most of the money that we see left on the table on encounters that have been completed and work that has been completed is non-covered services, mostly benefit limitation, sometimes providing care before the pre-authorization is back. We recommend that you don't schedule appointments until the pre-auth is back so that you can prevent this from happening. Failure to complete clean claims. If nobody's checking to see if your procedures, your codes are actually transferring over to billing correctly, you may want to have somebody take a look at that, even if it's just for a week of time, just to make sure that that process is going through. It's not just dental, our billing departments are having staff shortages as well. And so it may be somebody doing dental billing that doesn't have any dental experience and isn't familiar with dental billing, and it is different. Medicaid is easy. Commercial insurance on dental is not easy. So if you don't have somebody that is familiar with it, there could be revenue that's falling between the cracks. I like this percent of gross charges. We recommend that you have it between 60 and 65% of your gross charges and what you're collecting. If you don't, it doesn't mean that there's anything wrong, but you may want to take a good in-depth look at your revenue cycle, make sure your fees are where they need to be, make sure that that your codes are getting pushed through into billing. Again, with the AR, and these are dental only, you only want to know what dental AR is. If you have too much, if your percentage of AR is over 20% past 90 days, you may have an issue with one of the payers, or maybe you're just doing a claims management issue, or time. You're not getting your claims and your denials turned around in time. And then fees, potential missed opportunities with fee for schedule. This is where a higher commercial insurance can benefit your program by measuring your procedures per encounter. If your procedures per encounter are below 2.5, then I would take a look at that and just see exactly what's occurring during these dental encounters, just to make sure. That's a Medicaid compliance issue. But it also is a good way, if you can do 2 fillings on commercial insurance instead of 1, you're going to increase your revenue, and it's better for the patient. We all know quadrant dentistry is what HRSA wants us to be able to do when possible. So again, if it's not possible, which we all know a lot of times it's not, we just need to make sure that we're documenting appropriately for those encounters. Full fees, something that you should be looking at. Make sure that your fees, your full fees, are at least covering what your commercial reimbursement is. Sometimes it's not, and so you're leaving money on the table. They're not going to, if you're charging $10 for something and they'll pay you $15, they're going to pay you $10. So make sure that you're maximizing that full benefit for your programs. So I'm going to quickly run through this because I want to give you time to ask questions if you have any, or give me great suggestions that I could pass on to other health centers. But management of self-pay patients, eligibility, these are front office issues. Again, staffing shortages in front office. Some of these staff are trying hard, but they don't know anything about dental. And the problem with frequent turnover is that it makes the orientation and the training program almost impossible to be successful. Making sure that we're documenting right. Again, that patient registration and checkout, we need to make sure that all of their information is accurate, not just in there. That we talked about the prior auth. And then ongoing evaluation of performance. I used a monthly dental dashboard. I couldn't live without it. It told me everything that I needed to know about what was happening in my program, and I could monitor that for any downward trends and then try to figure out what was going on before it became a problem. So this next slide. So I was evaluating a fee schedule, some dental fee schedules, and I'm a hygienist. I have never heard of this. D2975 coping. And this was the reimbursement, $700. Now, unfortunately, that's not what they mean for coping. So we can't charge this out, but wouldn't it be awesome if we could, because that's what we're all doing right now. So I'm going to end here. Let me go to the end. I'm going to end here. There's some slides on leadership. Lorraine has those. You're welcome to this slide deck, and you can look through those. My email, my phone number's on here. Any of us at D4 would be happy to send you resources or to answer any questions that you may have. So thank you for having me. And if you have any questions, please, or suggestions that I can spread to other health centers, I know that they would be really interested in hearing what you guys in Arizona are doing in your health centers.
I quickly see a question in the chat from way earlier in your presentation. Do you have any information on the state rank of Arizona for RDHs and dental assistants? I think you were just mentioning dentists.
For salary?
Yeah.
I didn't find rankings for that. I just found the average, and that was salary.com. So no, I'm sorry. I do not have that information for hygienist or RDHs. I'm sure it exists, or DAs. I'm sure it exists out there somewhere. Danby would be a good resource for the dental assistant. And then ADHA, American Dental Hygienist Association, they have a lot of resources about salary levels for dental hygienist.
Great, thank you.
I have a question, Melinda.
Yes.
The dental assistant growth, you have a ladder.
Yes.
That you've made. I've been trying to work and do something in that direction. I can't really follow the model our medical department has because the criteria they have are different. Mm-hmm. What criteria do you use besides time for them climbing up a ladder?
Time is one. Level of experience. Evaluation by their dentist is one. How are they doing at the level that they're at? And then each level tends to add some extra responsibilities. So whether it's procedure based, level 1 maybe can do fillings. Maybe level 2 needs to take up a little bit more responsibility on some of the more involved procedures, whatever it may be. Always I noticed is that they do turn sterilization into that. And the top rungs are responsible for not doing the sterilization, but responsible for making sure that it's going right. And then you have the expanded functions. Some of the health centers are utilizing that ladder to promote some of those dental assistants to clinical management, clinical leadership. I think that that's they are good at that. They're used to managing the clinical aspects of care that we provide. So I'm happy to send you, my email is there. I'm happy to send you all of the different ladders that other health centers are trying that we have in our files.
That would be great. I'd appreciate that, at least to give me a starting.
Yeah,
point.
absolutely. Absolutely. Okay, anything else?
That's my dog. I just had two quick comments. I guess the first one was in the beginning of your presentation when you were kind of giving approaches to retention. Would any of those look a little different for those health centers in rural areas?
Well, rural areas are really tough for dentists and for physicians. Those of us who I live in a very rural area. Those of us who are auxiliary staff, we don't tend to travel like dentists and physicians do. So if you're fully staffed in rural areas with auxiliary staff, that's great. If you're not, then yes, it's different. So maybe really making sure that you're competitive in salary. And I know that it's tough for those of us because we're worried about sustainability right now, but we got to find the money from somewhere. So the number one thing is insufficient pay. I think if you are in a rural area, you need to make sure that that number one reason is not a factor for your center.
Thanks. And then the other thing is yesterday I was on another presentation on workforce, and it was just kind of a neat idea, I thought, for retention. It's one of the health centers. It wasn't in Arizona. I forget what state it was. But they were looking at kind of the salary and giving them bonuses in that way. But one of the things that they said was childcare was a big impact on a lot of their staff. So they would work closely with the childcare services in their area. I mean, if they had any, to work together and partner on how they can work with the new staff. And if they can't have discounts or pay for the childcare, they would work with the childcare services to at least reserve like 5 spots for them at minimum. So if someone's coming into a rural area or they may need childcare services, they'll know that they're going to have a spot there reserved for them. So that was pretty neat.
I think that's awesome. And I've heard that too. Some health centers have even considered putting a daycare center in. Some of us have Head Start programs. So yeah, I think that that's amazing. And I don't have that on the presentation, but you know what? I'm going to add that on there. So thank you.
Yeah. All right. Any other questions?
Okay, well, thank you guys so much for having me, and enjoy the rest of your meeting.
Thank you so much.
Oh, let me stop sharing.
Okay, so we're going to have Jennifer speak next, and she said she's going to be on like 2 minutes after 1:30. So probably like in 5 minutes. So is there anything you all want to talk about or give any updates on while we're waiting? Was anyone at the NOAA conference? You want to share something that you learned from there? Dr. Hillier, I think I saw you there, but then I lost you. I was like during the networking hour or 2 hours on that first day.
Yeah, it's like all I do there. I know I saw Bruce there, I saw Alan. Oh man, if I saw others I saw Neely was there. I saw Amanda Pinder from El Rio, she was there. I thought it was, I love NOAA, so I thought it was a great conference. It was really good to see colleagues again, but I really honed in on risk management stuff while I was there. So that was where I was. But yeah, I'm all over the place at NOAA. I enjoy NOAA a lot. risk management and quality, value-based care and those kinds of things is what I was tracking. If you said hi to me and I didn't see you, I'm really sorry.
Oh, no, it's okay. I think I saw, because we've never met in person. So I was like, I think that's Dr. Hillier. And I was like, but then I lost you at the end of there were so many people at the networking part. So Well, thanks for staying on, everybody. We're almost done. Just waiting for Jennifer to log on. Her section should be pretty quick. She's kind of just giving us an update on that adult dental case and dental therapy.
Oh, looks like a couple people jumped off.
Yeah,
Given what we just heard and what we just experienced in the last 18 months or so on the DA front, should we consider appetite to try and do internal DA training in a cooperative manner amongst our health centers?
I'm for it. I want to hear what everyone else thinks.
Been doing a kind of a, I don't want to say like grassroots effort in it. It's like once a month on Thursdays, or I don't remember at the time, but during lunch, but just kind of a best practices that other health centers across the country have had, but I would love to have one. I'll be honest, we've done really well training like people with no dental experience, but they cannot pass that X-ray test. Lori's our manager for dental. So I would be more interested in like a RHS safety and just like if we can rent somebody, you know, if you contact Danby's like, oh yeah, just here's our test materials, and it's a hard test. It's not easy, and we have some girls who have tried several times. So it's just a big challenge for us. I mean, I'm on board, Bruce, with, you know, a collaborative together with our health centers, but it's just so that is our biggest hurdle right now is that.
Well, maybe that's a seed part to start with.
Yeah.
You know, we want people to get it within the first 90 days, and that's been difficult to have people achieve. And then we wanted them to get coronal polish after that. We just decided yesterday, well, why don't we make coronal polish the first thing, because it's way easier.
That's exactly what we did. So coronal polish is way easier. Our DAs have just rocked that one. And so we've done the same thing, Bruce. And we have a career ladder, a great one in my opinion, but you cannot pass it. You can't even get to the first level if you don't pass that X-ray test.
Right.
And so, correct.
Yeah, well, it sounds like maybe we need that then. Start with that. In Washington, the Primary Care Association had an MA apprenticeship, and it was a state registered apprenticeship, and for a number of years, and it's been successful. And so they decided to, you know, there was a desire to get that training on the DA side. And in fact, they first came and said, should we start our own EFTA program? And everyone said, well, let's get dental assistant training first, because, you know, just getting people hired has been a challenge for a number of years. It was interesting to see that they tracked it since 2015, that was a shrinking thing. But anyway, so we started that. The challenge was the supply of interested individuals was mostly on the west side of the state, so on the other side of the mountains.
Mm-hmm.
So Seattle and the coastal corridor, and the need was mostly on the east side of the state.
Great.
And so we ran the program for a number of years, and the program was fairly successful, but we were always just short of the numbers that would have made it self-sustaining. So we ran it for about 5 years, I think, and then backed out of it. But we'd really done some good effort to try and get the program organized well. So you needed someone at the health center that, you know, would make sure that the apprentice was getting experiences in the right order to comport with the didactic that was, you know, online and off site. Anyway, it worked very well, but I was thinking earlier today, and if maybe we ought to reach out to them and see if they'd give us the package.
Yeah, I think that would be great, Dr. Wilcox.
So I know they went through a name change. There used to be Washington Association of Community and Migrant Health Centers, and now it's, well, anyway, you probably know who the primary care associations are, Lorraine, but Amanda Nicholson was the person over there.
Okay.
I know I've got her old email address, but they probably updated it. But we can probably figure that out.
You said Washington?
Mm-hmm. I think they shortened it. It's like Washington Community Health Association or something like that, but just, you know, went from 12 words down to 5 or something like that.
I think someone from the Washington PCA was actually in a meeting I was in at NOAA, so I could easily find who is over there right now. So.
All right.
All right. Hi, Jennifer.
Hello. Sorry, I'm a couple of minutes late.
You're fine.
I made it from Douglas to Sierra Vista, and I'm sitting in the Sierra Vista Chiricahua Health Center. So
Oh, okay.
yeah, we ended up figuring it was that or a Starbucks or McDonald's Wi-Fi, so they offered this. So yeah.
That's good. That works out.
Yep. So a few updates just for any of you. I don't know, I probably have met me, but just in case, I'm the Senior Director of Government and Media Relations. And when Tara Plush retired, I took over and working with her, or what she handled. One of the things that's there in general on a couple aspects is obviously we have the dental lawsuit, and I'll go ahead and give you an update on that. The Ninth Circuit had ruled earlier in the summer that FQHCs do have a federal right to payment for dental care, chiropractic, ophthalmology, and podiatry services. And they sent it back to the Ninth Circuit. This was the Ninth Circuit. They sent it back to the lower courts, to the district court, to determine what limits would be appropriate. So it did allow for limits on how much coverage, but it was what would they be? It didn't set amounts on that. Access, the legislature in the meantime, or right around that same time as the ruling, passed the chiropractic bill, allowing chiropractic services as an access covered service with certain limits and requirements, but they did put that in there. So Access said, hey, look, because the Ninth Circuit thing had talked about chiropractic wasn't being covered at all. Dental was being covered just for emergency care, a few things like that. So they said, look, we're now covering chiropractic, so rethink your whole thing, even though it really had nothing to do with whether the state was covering it that way. The Ninth Circuit just recently, let me actually look at the date, rejected that and sent it back. Actually, we got notice November 29th, so it was very recently. The Ninth Circuit took them a couple months, but they finally said, no, this is still going to the district court. We reject that argument. Our ruling still stands. The fact that you have some chiropractic service doesn't change the fact that FQHCs have a right to payment for those 4 services. So it is now going to go back. It'll be a few weeks again. It'll go back to the district court for them to look at. They'll set up a process. We'll be looking at whether the refusal for access to cover preventive, diagnostic, restorative adult dental services violates the right of FQHCs for payment for those for dental services as well as the others. Obviously, our focus is on the dental. And then what limitations, if any, are allowable and justifiable? How do they define those? Is it enough that the legislature says you can do 1,000 for emergency care, but then they're not providing anything else? So what else should it be? That kind of thing. So that's where that is. So it's still a very positive, good news in our favor. I will tell you there's a separate case the Supreme Court heard in October dealing with the Federal Code 1983 is the key part. It's not the full code name, and I don't remember the name of the case right this moment. We sued based on the right to sue to enforce federal law under Section 1983. I think it's of the Social Security Act. The court did a hearing in October raising question of whether anybody, either any entity, any person, anybody has the right to sue to enforce federal law, or whether basically it would only be the state that would have the right to do it. If that happens, we would actually lose our right to sue. Not only on this case would be the first to fail, but it could even affect our right to force access to pay us our PPS and everything else. So it could have much bigger ramifications on a whole host of the types of services, possibly even into behavioral health, all sorts of other places. So don't know, we're not expecting a ruling from that until later in June. Reason I bring it up is even if we get the dental, I think until we know for sure where that's going, we'll find out what the attorneys say, but I am expecting we will have some hesitation or wait until we get the ruling in both of these cases before we go full-fledged of expanding and some of that kind of thing to make sure we don't have it for 2 or 3 months and then it gets taken away because of the other rulings. So just kind of putting it on the radar out there. Any questions on that part? Okay. The next piece of it that relates to that is this year, Children's Action Alliance, the Oral Health Network or Coalition, I don't know which one they're called. Some of those groups are looking at going for adult dental as a whole, not just for pregnant women. Which, by the way, if you guys had heard the rumor, we all heard the rumor that that CMS was now expanding and requiring all health centers or all states to provide dental care for all pregnant women. That was a bad rumor. It got started. CMS had one little thing recognizing when they approved North Carolina's state plan amendment, referencing that now all 50 states have coverage for dental care for pregnant women. Then the Dental Association, the American Dental Association, put out a press release saying, this is really awesome. This is great. That left the impression that it was a new service. It wasn't. Access, and people have verified, Access interpreted the service we have for pregnant women with the emergency dental care for pregnant women qualifies that Arizona has care for pregnant women for dental care. So that's all that it was. It didn't provide a new coverage of anything other than what we already had. So that was a bad rumor we all got excited about, but unfortunately went away. So, so now going back to the upcoming session, they are looking at doing it for all adult, not just pregnant women. Obviously, if they end up having to compromise, they'll compromise back to only pregnant women, but the goal is to ask for all of it. The plan right now, and this is still in flux, this is still in discussions and running numbers. The plan right now would to go for that for uncapped, where they originally we had talk, and this may be where it goes, that take the 1,000 that's emergency, spread it to 1,000 for comprehensive or emergency, possibly out on extra if they have to have anesthesia because that costs more, some of that kind of thing. Some different iterations of that, but at this point they are leaning towards, and again, subject to change, leaning towards introducing a bill that just covers adult dental with no caps whatsoever. Gives more negotiating room as they move forward. Plus you now have a Democrat governor that'll be more supportive. So where does this end up in negotiations as part of the budget, of course, all of that kind of thing. Obviously we have no idea for sure where this session is going to go and what it's going to look like. It's the first time since 2008 you've had divided government with a Democrat governor and Republican legislature. And there's fewer moderates now to work with the Democrat governor, so we don't know for sure where it'll all go. I want to make everyone aware that because of the lawsuit that's sitting out there that is talking about limits and what are those limits for FQHCs, but has already ruled we have a federal right to get paid for these services. We are planning to, I am still in those meetings, the coalition discussing it, being aware of it. We will probably not, and ask you all to not take a public statement or take a public position in support of the adult dental bill, primarily because if we take it, even when it's uncapped, it's harder to pull your name off of support when if it ends up being capped at 1,000 or 2,000 or whatever, then the state could say, hey, look, you took a public position in favor of a $1,000 cap, let's say. So you're now agreeing that that's the cap for the federal lawsuit that we have. And so we want to be very careful to not be on the record appearing to even support any sort of a cap, because we might could get $3,000 or no cap or whatever. So we're going to be kind of careful on some of that. We'll still be involved. We'll be, quietly supportive, but not publicly, not making public statements. If we end up deciding to make one at some point, I'll have a disclaimer from the attorneys that this in no way, takes a statement on our lawsuit and so forth. But I think for the moment, we're leaning towards being a little bit more, we can mention we're supporting it. We just don't want into legislators one-on-one. We just don't want any public statements to that effect, and so forth. So any questions? I think it's exciting that they're going to go for it and have chance. Last year, the focus was really more on postpartum care. The adult dental bills got introduced, but they really weren't a priority. The postpartum for 12 months instead of 60 days was the focus. This year, adult dental will be one of the primary focuses. It's just, we're going to watch it from kind of a hand's length. So any questions or comments, feedback on that? Okay, if you have questions as we go through, especially as we end up getting into some of the negotiations where, like I mentioned, the anesthesia or other kinds of stuff, feel free to reach out. We'll see where the lawsuit goes. They'll kind of both be moving forward at the same time. So that may make a change as well as it goes. But that's kind of where we are in that. The other big piece that I have of news, and I had mentioned it back in June to see if you guys were even slightly interested. We have now, the Alliance has just recently been awarded a grant from Pew to focus on and promote dental therapy. So that bill passed several years ago. When it passed, it was limited for dental therapy at FQHCs. And what we thought at the time was tribal health clinics as well. Access is interpreting it. My understanding is there was that it was thought that because tribes are not under the same license and governing in a certain way, they have some sovereignty, that we didn't have to specifically mention them. Access has said, well, because you didn't mention them, they're not eligible for reimbursement under the dental therapy that there otherwise was going forward. So we will probably be looking at a bill that's going to be much more just a technical correction to make it clear that this is for FQHCs and tribal health clinics. So we may have that's just a fairly simple cleanup from where everybody intended it to be, but has been interpreted to be differently. The other part we're going to be doing, it'll be with us, and then also our contract lobbyists who first had the Pew grant, and they are Pivotal Policy Consulting. We'll be going around, combine some together, some separate, independent, and so forth, doing two parts of this. This really is to take dental therapy to the next level. We'll fix that part. We'll work with Access on the state plan amendment to go on and get that put in for reimbursement for dental therapy, so we can get that in line and have them eligible to be reimbursed. Then we're going to do a couple things of working with the education institutions, whether it's AT Still, the community colleges, NAU, the other universities around, to see, hey, maybe not next year, but 3 to 5 years from now, are you interested in, will you start a dental therapy program? Is there interest? Let's kind of start moving in that direction. On the same hand, we'll then be working with the dental hygienists, not only in the health centers, but the associations, the different levels that already have some training that would just need some extra training to become a therapist, to show the universities, look, see, or the education programs, there is interest, and these people are willing, these workers are here, they're willing to take the increased classes to become therapists. The other piece will be coming out around working with all of you to, I don't know, and this is a question I'm going to have in a moment, how much you all are aware of it and know of it. I know it's been talked about before. I'm assuming you're aware, but what information do you need from us about the program, about how it's going to work, about what steps, and is there interest? Let's build the interest and generate that. Okay, we're going to have workers that are willing to go to school to become therapists. Well, then after that, we'll have the education programs to actually train them, and then following that, they'll have jobs and places where we're willing to employ them. And again, limited right now in the law to FQHCs and expected to be tribes as well. So AT Still and the others are not going to do it if there's not a place for them to get jobs and stuff. So it's kind of that full circle around working all together to do it. Probably at some point towards the end of next year, actually have a half-day conference or something where you bring a bunch of you together and have an education, everybody together, and kind of put together the plan. There will be some work and looking at, one of the things Pivotal will help with is out of state. Other people are being trained as dental therapists. What can we do to attract them to come to Arizona? So if some of you are interested in hiring one now and not waiting, let's have those discussions, and we'll be looking at that, that kind of thing. Especially as we get it, that once they get reimbursed in Arizona. So we have to get the stand plan amendment done first, but then once they're being able to be reimbursed, let's see about bringing them in. I think there may be, or they think there's some philanthropic and grant money out there that could help to do that and bring that in and help to facilitate some of that. Groups out there, again, huge pushing this around the country, not only with us that they were critical to get signed on, but with NAC has a contract to focus on this, others do as well. So that'll kind of be what we'll be looking at, working with the dental directors and dental departments to kind of have these conversations and see where it goes. So how about questions on that?
So now that we're rewarded that, does that work kind of just start now immediately, or is there a timeline?
Yeah, Dr. Nelly was setting up for the first meeting for the end of January. I was kind of pushing for sooner than that,
Yeah.
to kind of get it started. So I've been out of the office most of this week, and last week I was sick. So I will touch base with her on Monday to kind of see what can we do to make it sooner, that kind of thing. And a lot of it's just going to be having meetings to get started and having
Right.
conversations, putting together flyers. I'll update you guys regularly on here, probably get feedback. I guess that would be, and that'd probably be my first question for you guys. You know, you understand, you know, the scope, you're aware of the dental therapy and all that. I do know the rules, by the way, are going through. They're not quite ready for GERC, but I think that's virtually the next step, that I think the dental board has pretty much put together the rules and they're ready for the next step of the approval. So that would be the other. We also obviously have to have the licensing. They have to be able to be licensed in Arizona, but that's close to being finished. So that and the reimbursement. And then after that, we could start hiring them. But part of my question will be whether you guys can answer now or later. You know, how much do we need to do of the first part of it? Here's their scope of practice. Here's what they can do. Here's how they fit in. Here's how you become a therapist. Or are you all aware of that already and you're ready for the next part of the information? So if anybody has feedback on that. Okay. We'll be reaching out to figure that out. I don't want to give you information that's like ABC when you're already down at, you know, LMN and so forth. So we'll have to try to do some of that and figure out. And I know people may be at different aspects too, but yeah, want to make sure we're providing relevant information of what do you need? And that's the other question. What do you need from us? You know, it is part of this bringing it together and having it, but what do you know, when I checked in June, you guys did show interest in having dental therapists with all the workforce challenges and that kind of thing. So I'm still no yet. We don't have anything for sure, but hoping we will have some workforce funds and grant money coming up soon from the governor. But we submitted a plan. We just don't have any confirmation yet, but hopefully we're hearing good thoughts. So yeah, those are kind of my updates on the big aspects of it.
Good.
Anything else you guys are hearing or have questions or hearing of other bills that would be relevant? Okay, I am fairly certain Bodex is up for renewal this year. There was a committee of reference this weekend, and I'm pretty sure I saw it on there. Access is also importantly up for review. The committee hearing of legislate got canceled because there were not enough legislators for a quorum. So we're not exactly sure. Does that mean they're not going to have it until January and just do a committee of reference along with the session, which is not the way it's normally done, but that may be. At least 3 of the members on there, including both chairs, lost their elections, so they are not returning. So I don't know that they were the ones that didn't show up for quorum, but you know, there could be an aspect of that too. So, but that is, I'm pretty sure I'm 98% sure Bodex was also on there. So I'll monitor that if there's any controversy. If you guys have any suggestions you want to put in for Bodex to be improved, that would be one thing to let me know. That would actually be really good. So if you're having problems with Bodex, these are often good times to deal with that and get some concessions and fixes and so forth. So does anybody have that while I'm looking it up? No. All right. If you come up with anything, let me know. That'll be one thing. Again, an opportunity. If there's not a lot and we don't have anything one way or another, then I'll just kind of watch it and provide updates as needed, but I'll put in, you know, we'll see where it's going. If it's moving forward easily, we won't even worry about a letter or that kind of thing, but we'll be there to do it in case. So, yeah. It's under the house. I'm going to check and make sure, although it did get canceled, but yeah, so, oh, I can't do, there we go. All right, I'm open for any feedback you guys all have, any questions, anything else?
I don't see anything.
Okay.
All right.
Yep. All right. Well, thank you very much. Let me know and we'll be in touch. We'll be
Yeah.
coming around to see you all. I'll be making trips to see you and stuff like that. So
Thanks,
All right.
Jennifer.
thanks very much.
All right, bye.
Bye.
All right, so we have 5 minutes. If anyone has any last comments, questions, things they need to say before we end today. I know we lost half of our participants, so.
We have Brianna live though, so.
I look so rough. I'm so sorry. I'm like, oh, my video's on.
Hi,
Yeah.
Brianna.
It's been a long 3 days in my house. So I want to go back to, yeah, I'd love to see if we can get some sort of, like you said, package or something. The biggest thing that I need, honestly, is, and again, she kind of touched on it, but you know, a lot of us, the three of us that are in here right now, are rural, and so you know, there's not a local training program for my DAs to go like sit on Wednesday nights at 5 o'clock for, you know, 6 months and then take the test. I did stumble upon somebody, you know, rabbit hole down Facebook, who she's a DA, she works in Arizona, she used to be, but she does her own training program. And I asked her a lot of questions because I was like, it needs to be virtual. Are these pre-recorded? Is it on demand? Can my team ask you questions? What's your pass rate? You know, so there's definitely some things, but we just keep running into roadblocks. You know, we'll call Danby and Danby's like, here's some practice tests, which we already have. You know, or, you know, our DAs have shared them, the ones who have passed or the ones who have paid for some prep materials. So Danby is kind of a dead end, at least, and Lori can speak to that. She's the one that kind of reached out to them, but I don't know if it would help from the PCA's perspective to talk to Danby, but or to, you know, can we get a group rate or something? But we just, unfortunately, that's my biggest hurdle right now with DAs. No, personally, anyway.
Well, and there's really two different approaches you can take. Yeah, it's a prefab test. And, you know, experienced studiers like we are, know that you study just the tests. And then, you know, you can knock it out. But a lot of these, a lot of dental assistants, some of them are really sharp and really smart, but some of them never develop good study skills. And the minutia that seems to be required to memorize from text or other sources is just immense. So it feels like we need to put on a course. That's what it feels like.
I agree. We've got some, sorry, Lori, I don't, Lori's out on the northern part of our county today, but and that's, Bruce, you're absolutely right. So we have a DA who has taken it several times and she has failed. Now, they did just allow you to take it from home. So she definitely has this, like, I mean, and I'm not trying to go, an anxiety disorder. She definitely has this test anxiety disorder. So, you know, she just like really, you know, and this is one person, but there's, you know, we've kind of thought of every excuse possible. Like, okay, she gets anxious. Okay, her main language is English is her second language. You know, there's a lot of reasons, but so she just failed again for more than the third time. Yeah, and the X-ray test, the RHS test, and she's such a good chairside DA. She's so good, but she can't push that button until she passes this test. And so, you know, she's a team player. My point being, we're trying to pull out all the stops to keep her. And I think we will, but she's just frustrated. But the point to your statement, Bruce, she's 100% trying to memorize this stuff because she doesn't get it. And then when the question is not on there, you know, and ask any DA, you know, somebody's like, oh my God, mine was full of landmarks. And somebody else is like, I had like 2 landmark questions and a bunch of film processing questions, which for those of, you know, we don't use film anymore. So then, and I still had them in dental school 10 years ago. And the question is, why did your film look brown? I'm like, I don't know, like, because the ScanX didn't work. Like, I don't know.
We
You
didn't.
know, so
We didn't do it right.
so there's definitely, I agree, Bruce. I would love to do something, because I'm glad you said that, because I almost asked my docs, would any of you be willing to, like, meet 1 hour with our DAs? But because they'll come to me. I don't know if they come to you guys, but the DAs who are studying for it will come to me and be like, Dr. Hillier, can you tell me? I'm like, no, I can't, because I don't remember KVPs.
I'm not going to pass that test because
Yeah,
I'm going to have to study it all over again.
you would. And the book,
Then you
my
don't
understanding
remember
is
it.
that
I
book
took
is
mine in
pretty-
1974. What am I
Right.
going to remember? It was all old
No.
stuff.
Yep. So I'm the same way. And I would certainly, I am here to, if we want to do a team effort here, I think we would have other dental directors who are not here today interested. And maybe we break up the current book into chapters that we kind of present on. We can record the presenting. And that way, that's not a bad way to go. And maybe I'm just thinking this myself, and not that I have a bunch of free time, but if we broke that book up, and the book I'm talking about is the Danby one, that covers everything. And we, section by section kind of assigned it almost like a dental school. And that way our team could, and any of our DAs that have questions could ask that dental director or hygienist. It can be a hygienist as well if they're interested. And they can be a little more specialized in that area. And then they're actually getting feedback and questions answered from I don't want to say a real person, but I think it's a lot more approachable to us. And I'm able to say, oh, I know Bruce, and I know Alan, I know Neely, I know Amanda. Like, I wonder if that would be something that, the PCA, I don't know if the PCA can help, like, organize or maybe fund, or, because the test is expensive to take. The test is, Lori, how much is the test?
It's $275.
How much?
$275.
275. And then, in our career ladder, we have, a CDA is built into our career ladder. And if the RHS exam is part of the CDA exam, but that RHS exam is only good for 4 years or something, like, to qualify for the CDA. So anyway, I think it would definitely help build our teams. And maybe I'm tooting, obviously I won't shut up about this today. Apparently I'll stop talking in a minute, but this is a hurdle for me in my health center. And so if people were willing to help out, I would, and I can send that email. I feel comfortable talking with a
I'm
lot of
on
our
that team. I'm having the same problem with several
Okay.
of my assistants, and we just
Okay.
paid for them for travel and the test once. Then if they fail, they have to pick it up again. So
That's
it's a
us.
big deal to keep paying for it.
Oh,
And
yeah.
Dr. Hillier, I know that in the past, years ago, when we first had this problem, there was an instructor from PIMA, from the side, that the dental instructing, that used to give like a course, would do it once a month, and she charged a certain amount, and people benefited from that significantly, but she no longer does that. So I think what you're talking about is exactly that plan system. Somebody that they can reach out to, ask those questions, know the inside and out, and can really help guide them with this.
They were accepting licenses from other states. Now they are not. They won't give reciprocity to an X-ray license from California.
Right. We had a DA who was an RDA in California. And I mean, like you just said, Alan, she'd been an RDA for years, but I've been a dentist for years. Like, to take that test again is very hard. So I don't know. I guess I'm open to, we can also contact the schools right now. A lot of our DAs,
It's new online at Coconino Community College.
and we just started our college down here, Cochise Community College, just started a DA program as well.
Yeah.
So maybe
I
there's,
wonder if they're buying a package. And it's the
and if
same
there's
package.
faculty, I think the biggest thing is that there's faculty that, like, they've got to have, these DAs are trying to memorize these books, and, like, they do not understand the bisecting technique. They just don't get it. Like, they're just kind of looking at it, and they're seeing, like, the cones like this and your dotted lines like that. They don't get it. They don't get why they're doing that. And so why they're studying it. They're
There
just,
should
it's
be a
hard.
bit-
It's a-
I bet you could make a shadow box that would show that, you know what I mean?
Sure.
Mhm.
Well, I mean,
Like,
and I'll try to tell
there's-
them in the mouth, like, here's where my film is up here. My
Yeah.
X-ray cannot do this. My X-ray has to cut it in half, like bisect it. And so
Yeah,
anyway, but my point being, that's kind of, so Alan's kind of suffering with the same thing. You know, I don't have the luxury. So what she kind of touched on from D4, you know, Neely and so she's Adelante and Dr. Pinder at El Rio, they're like, oh, you can't be hired if you don't have that. I'm like, well, I don't have that luxury. Like, I need DAs that don't even know tooth numbers, and I'll teach them.
Mhm.
You know, and so the bigger cities, I don't know if they'd be willing to help out. I mean, and I say that because they might not have the issue, so they're kind of like, good luck. But anyway,
yeah. Well, you know, if we didn't have enough mass, we could consider reaching out to some IHS facilities too. They might be running into similar problems or well,
do
they
they
don't
have
have
that?
to pass the test, so.
I was gonna say, do they have a
Yeah.
requirement?
Or-
Yeah.
Here, come take this test with
Well,
us.
We had a couple of our staff took the MedCerts program, but it's just the online version of the dental assistant book, the most current edition, the modern dental assistant book. It's literally just an online version of that, and in that is X-ray stuff, is the X-ray, you know, training or whatever. But again, it's all online. There's no hands-on. There's no and unfortunately, this DA, she passed it all, except she can't pass the X-ray certification. So we've tried, you know, giving these DAs who don't have any kind of training, we've tried giving them a program to do this with, and it's a very expensive program. It's $4,000 just to do this book online, and then they still can't pass that X-ray. Sorry, I was just throwing that out there because I was like, oh, we have done this also. And we-
I have to jump off, guys.
Okay, thanks,
Gotta-
Dr. Wilcox.
I'm in another meeting already.
See you, Bruce. Take
So
care.
We'll see you. We might need to gather together and talk about this in the next week or so and come up with a
Yeah, I hear all
plan
of
to
it.
work on it in
I'll do
January.
whatever we need to do. I mean, I'm just, they keep failing. And I'm not gonna, they can't be fired. Once they're hired,
Same.
they're with us forever.
We're the same. Like we've got people. Sorry, I've got to hold on. Sorry. We've got really great team members here. They just can't pass this dang test.
I
What's
know.
his name? What's his name?
His name is William, and I'm on my iPad, so it's like catching him. And
I
I'm
know
like-
it's moving.
I'm like, this
Hey,
is so.
William.
Okay. So anyway, Alan, I'm on the same page. I don't want to fire these people, and they're great employees and good DAs. And so so I think, I don't know Lane, if you want to send an email, I'm pretty persistent and I can bug a lot of people. I don't know what our best approach is. I don't know if people have contacts at the community colleges, because gosh, Phoenix has like 3 of them, of course. But is there somebody who would be willing to, obviously I don't think anybody would do it for free. I mean, unless it's the dental directors who are getting paid, as it is, but because I'd do a chapter summary or something, but
I'll volunteer for that. I mean, whatever
Yeah.
you come up with, I'll give my time for that. We actually have a local dentist who's offering he's teaching ladies to become, and men to become dental assistants. But he
Okay,
doesn't have them take the X-ray test, and he doesn't have them do a coronal polishing. So like, they do this hands-on class with him, and it's just like a waste. So.
right. And
something
so
to-
I think, let's see if, so the first question on Harvard, I guess we can look at this, but is what's the best resource for it? I think it's that X-ray book, I think it's and Lori, I'm looking at you only because I know that I've seen it, our DAs have shared notes left and right. And so there's a copy of a book, and whether or not it's us doing it or it's, I would record sessions. you know, I don't know if we do short straws. I don't know how many sessions there are in that
Also,
book.
would it be a bad idea to have one of the assistants who recently took the test talk about it?
Yeah. And
Yeah.
just, cause we currently have 2 right now that, one who she just doesn't get it. It's tough. And then,
3.
yeah. And then we have another one who just started a month ago. Fantastic dental assistant, but she worked in Mexico, so there were no rules. So anyway, but yeah, I'd say if we want to have a separate powwow, or maybe like I said, Lorraine, if you want to send an email to,
Yeah,
and I'm not trying to eliminate like managers, Lori knows this, but like clinical, like people that know this or are willing to study it and do a chapter summary for the DAs. And this can be, I don't care if it's a PC, like the PCA can hold rights to it and we just borrow it as needed. The health centers that are in the PCA can borrow it as needed. And, you know, and if there's questions, you know, I mean, I'm here forever and ever, but, you know, I just, that's what I think I'm at right now is, gosh, our DAs can't afford to, I
right.
mean, we have a DA who has spent $1,500. It's just, and again, Alan, same thing. We'll pay for the first one, but and we reimburse you. So she hasn't been reimbursed, and then she signs up, and she's got to wait 3 months to get a test date. And I
know,
think it's a lot more
terrible.
flexible now. She said so. They just started letting you take it at home, probably within the last not even 6 months. And so she said taking it in her own home was much easier. Like her anxiety had already dropped. She didn't drive 2.5 hours to a test center, you know, but she still didn't pass. And she said, you know, I don't know if you've ever taken a test from home, but like, you know, there's a camera on you. So it's going to track like if your eyeballs go over here, you know, and so that you don't cheat. But, you know, I don't know what the pass rate is. I didn't hear how many. So, Alan, what percentage of your DAs don't have that X-ray test?
50% of my DAs. No, it's just my recent hires. And now we're not even looking at new hires without them having the licenses. So we have no applicants. I need to get past this because they're not doing their job. Everyone else is carrying their weight because they're doing the X-rays, they're doing the prophies, and I don't even do the prophies. But I did not know that they could do the X-ray test at least from home. So
yeah, that's just like I said. I don't even know if it's 4 months old, but it's very new. And so, but you know, we've got, like I said, it's a small percentage, but I think it would be an awesome resource to have indefinitely for our health centers, you know, like
15%, if you want a number, 15% of my dental assistants don't have licenses. And if I hire somebody else, it'll be 20%, you know.
Oh yeah. And like I said, we removed it, like the requirement. I mean, we follow up. We have it as like, cause we have DAs and we've changed, I don't remember if we changed the requirement, but like it was within 90 days that you had to be signed up for the test, but they need to study for 90 days. Like it's hard, you know? And so we've been very lax with it. And so then HR every once in a while comes knocking going, how come you have employees here that are not in compliance with your minimum job requirements? And then we fight the fight for them, and HR is like, okay. But you know, we had some who don't care to try. Like they're not trying.
Requirement away because we weren't getting any applicants.
Right.
Most of these gals, they can do it, they can do the job, but they don't have the license. So unless they get the license while they're working for us, they're not going to get it. They'll go work somewhere else where they don't have licenses. Some guy in town has a dentist that has a license in Mexico doing his SRPs.
Gross.
I know.
I'm sure there's mounds of calculus left.
We can't do that. Maybe she's great. Maybe she's great, but she's not licensed.
Right.
Yeah.
Yep. So, okay. I think that would be at least that's my kind of go-to at the moment is it's funny. We're talking about retention. I'm like, I need to recruit.
Well, I hear, and I'm taking notes of everything. So I'd like to kind of take a stab at kind of coordinating our meeting. I'm also going to talk to Janelle because I know she's way more familiar with with this, and gonna send some emails. Ask around first, because we also have our KHIC, and I know they do a lot of trainings, so they can probably produce training to help us figure it out where to start. So let me take a stab at it, and I'll let you know our next meeting, or before, separate from our DNPC meeting here, so we can do something separate, so we can start talking about it. And I guess the sooner we do it, the better. So
Right.
Right.
Right. I think, you know, right now, like we say, the big cities don't have issues with it, but they might. And, you know, if it's just, I think it'd be nice to know that, oh, the Alliance has a reference for that, or the Alliance has a course
yeah,
that, you know, your DAs can take and self-study. And, you know,
Right.
I don't know if it's, you know, once a quarter, there's a meeting, you know, or there's a kind of Q&A session for any health centers that have DAs going through it. Come to us with your questions, like, you know, but definitely a lot of flexibility. And yeah, Danelle's a great point of contact, or, you know, I know you know that. She's great. Don't tell Danelle you saw me in this, because I'm in the UDS training right now.
where does she go?
Oh, it's
Well,
like,
happy holiday.
it's like reading
Hope
the
to talk to
UDS
you
manual.
before.
It's awful.
All right, thank
today.
you, everybody.
Bye.
Talk
Bye,
to you
guys. Have a
soon.
good holiday.
You too, bye.